Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for the second in a series of three CMEO snacks on hypertrophic cardiomyopathy. This CMEO snack is titled Unmet Needs in the Current Treatment Approaches for HCM. CME Outfitters is the accredited provider for this continuing education activity. The CMEO Snack series is supported by an unrestricted educational grant from Bristol Myers Squibb. I'm Dr. Deepak Bhatt, Executive Director of Interventional Cardiovascular Programs at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. I'm joined today by Dr. Steve Amin. Dr. Amin is the Director of the Cardiomyopathy Clinic in the Division of Cardiovascular Diseases in the Department of Internal Medicine at the Mayo Clinic and Professor of Medicine at Mayo Clinic College of Medicine and Science in Rochester, Minnesota. Welcome, Steve.
Thank you so much for having me on.
In addition to CME CE credit, today's activity is eligible for ABIM MOC points. Once you complete the activity, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will then submit your MOC points. You can also claim this activity as a CME for MIPS improvement activity. Our learning objective for this CMEO snack is to apply current practice guideline recommendations to the care of patients with HCM. And we are very fortunate to have Dr. Amin here with us. Steve was the lead author of the 2020 AHA and ACC Guidelines for HCM. Steve, please go ahead and start us off with what every patient should know about HCM.
Yeah, thanks, Deepak, for having me on. And the slide that accompanies this is one that I've been using for a number of years now because hypertrophic cardiomyopathy is somewhat underappreciated and overly feared by people out there in the community. And so some of the things that we talk about is, first of all, letting patients know that they're not alone. The prevalence of this disease is approximately 1 in 500 around the world. And generally, with modern therapies, is compatible with a good duration and quality of life for the majority of people. But there are some important factors that we have to consider. One of those is that there is a rate of sudden cardiac death in hypertrophic cardiomyopathy. It is about 0.8 to 1% per year of HCM patients may experience a fatal rhythm each year. So that's an important part of the evaluation that we do. Secondly, because it is a genetic cardiomyopathy, we have to worry about their families and best ways to screen members of their family. And then the next couple of things that are important to talk about are, and the topic of today's is the management of patients with hypertrophic cardiomyopathy, and then what to counsel them regarding healthy lifestyle choices. So those are the building blocks that really form up the foundation of the counseling session I have with each of the patients that sees us in our HCM clinic.
Yes, really good stuff for patients to know. So what are some of the highlights that came out of the recent guidelines?
Well, as you know, the guidelines now have added a neat feature in the front of them, which are kind of the top 10 take-home points, which really kind of summarizes some key changes there. But I think I'll point out a few of them and not all of them, just for the sake of being concise for this snack. And so one of the things that we emphasized was the importance of including patients in decisions about not only their diagnostic testing, but their therapies. And that is because unlike some of our other diseases, which are very common, atrial fibrillation, heart failure, and coronary artery disease, where we have trials with thousands of patients randomized, HCM is not rich with randomized controlled data. So each of the discussions involves telling patients the nuances of why one therapy might or might not be better for them on a case-by-case basis. We also wrote into this guidelines, and one of the first guidelines to do so, the importance of referring patients to HCM patients for some of those critical discussions. Many cardiologists can handle frontline therapy for patients with HCM, but when it gets down to discussions about genetic testing or procedures that are specific for patients with HCM that aren't done at high volume at other centers, it's important that patients be offered the opportunity to avail themselves of the best possible care. And that's one of the unique aspects of the disease that isn't as common. I think that we also highlighted the importance of family screening, including children and adults, and the frequency with which you might do that. And I think in one of the other parts of this series that Dr. Marin addresses that with you as well. And I think that's an important thing for people to pay attention to. Lastly, we have evolved, well, not lastly, but we have evolved the risk stratification for sudden cardiac death and the selection of patients and counseling of patients who might be eligible for an implantable cardioverter defibrillator. And that is a constantly evolving topic in the management of HCM, and actually probably takes up the largest portion of the discussion in that counseling session with any patient. And then again, we'll focus on the topic of today's discussion, and that is the evolution of management in hypertrophic cardiomyopathy and some of the unmet needs that are there. And so we emphasize the role of first-line therapies like beta blockers and calcium channel blockers, and when you might move to more advanced pharmacologic therapy, or when in some cases you have to move on to an invasive therapy to help improve symptoms for our patients. I think that's a good primer on some of the big changes in the guidelines that came out this year.
Yeah, I think that's really great. I mean, it integrates a lot of the evolving science, and as you mentioned, the genetics is a big part of it. A prevalence of, you cited 1 in 500. Some sources even say up to 1 in 200. So
exactly, yeah,
it really is a fascinating area of evolving science, and it's terrific to see the guidelines keeping pace with all that. What about exercise and athletes' risk for sudden cardiac death? That's often a big concern.
Yeah, that's a very big concern, and it dates back. It's predicated on the fact that if you look at the population of patients who die and are found to have hypertrophic cardiomyopathy, it's overrepresented in the athletes who have died than it is in the general population. Up to 30 to 40% by some estimates of sports field deaths are related to hypertrophic cardiomyopathy. So clearly that means that being an athlete with hypertrophic cardiomyopathy is higher risk than being an athlete who doesn't have hypertrophic cardiomyopathy. But the nuance is, now that we're looking at sports and physical activity in the population that's hypertrophic cardiomyopathy, all comers, we do see that patients with HCM can get the same health benefits from participating in a healthy lifestyle, which includes slow to moderate intensity exercise. There have just been a couple of abstracts presented more recently, and we haven't seen them in formal peer review. They're trying to examine whether higher intensity exercise might be beneficial and or safe for our patients with HCM. So we're anxiously awaiting those data. The issue of the competitive athlete who is discovered to have hypertrophic cardiomyopathy and whether they can participate in that sport is really a highly controversial area. And it's one of the exact things that we do think that probably those patients deserve a conversation with one of the truly high volume HCM centers that deals with that type of discussion on a regular basis, because there are issues that the risk may be high, but yet in the randomized trials looking at sports participation among HCM athletes, we're not seeing that signal. And that's probably because the incremental risk of being a patient with HCM who participates in sports is small enough that we haven't seen enough patient years of at risk yet to detect that difference. So again, it depends on whether you look at patients who have expired versus living patients with HCM and the activity levels. And that's the difference. So I think that we can say without too much debate that, again, being an athlete with HCM is higher risk than being an athlete without HCM. But we're not clear how much higher the risk is to be a patient with HCM who participates in sports versus just being a patient with HCM.
Yeah, really a hopefully evolving area of our understanding, because of course, for young people that have HCM, this is a really big question.
Yeah.
HCM is challenging to care for and requires a specialized multidisciplinary team. What do the guidelines recommend in this regard?
Yes, absolutely. So you definitely need a team that has advanced diagnosticians, which usually centers around cardiac imaging. So you have to have a well-rounded echocardiographic laboratory that has all the modalities to it. And then there's this evolving field of cardiac CMR. I'm going to pause just so maybe we can edit that in. I think that's a really good point, that we do need all kinds of cardiac skills in an HCM center. Much of that centers around diagnostics, including echocardiographers and specialists in CMR. CMR has an evolving role in the diagnostics and risk stratification of patients with HCM, and I'm sure that you covered that with Dr. Marin in the other segment. Then the other people you need to have on the team include genetic counselors who understand how to counsel patients, whether they want to pursue genetic testing as their screening modality or whether they would prefer to do an echocardiographic-based surveillance interval. And then lastly, of course, if we are talking about therapy specific to HCM, such as septal myectomy or septal ablation, that is really where you need an HCM center that has high volumes and published outcomes that are top notch so that your patients are getting the best value and the best outcomes for their particular situation.
Great. Well, can you go ahead and walk us through the approach to the management of HCM?
Yeah, absolutely. So if we're talking about a patient who's already been diagnosed and we're down to talking about what therapies should we deliver for that patient. And we're going to talk about therapies for symptomatic HCM because patients who are not symptomatic really aren't required to start any medical therapies at that time. That would simply be followed on a regular basis to determine their clinical status and to make sure they were doing well. But if they're having shortness of breath or effort-related angina or pre-syncope, the most common cause for that is left ventricular outflow tract obstruction, which has been shown to be present in 2/3 to 3/4 of patients with HCM, either at rest or with simple provocation. The first line therapy for those patients is usually beta blockers and or the non-dihydropyridine class calcium channel blockers, verapamil or diltiazem. And we titrate those therapies to either symptom benefit or intolerable side effect. And many patients can be handled quite simply with those medications. It's also important that we eliminate potentially offending medications if a patient has other comorbidities. So patients who might have concomitant hypertension are getting vasodilator therapy for that. Well, the vasodilator therapy can actually make them more prone to symptoms. So if we can remove a vasodilator and add a beta blocker or add verapamil, we often get a very tremendous symptomatic benefit for those patients. We judge the success of therapy on how the patient is doing, not anything we measure in the echo lab. So if a patient comes back to me and tells me that they can do more, that they are now happy with their ability to get out and be active with their family, that's success. It's not an echocardiographic-based parameter. But if a patient is not feeling better or they're having side effects, then we have to think about the next line of therapy. And in the new guidelines, we kind of lump disopyramide therapy, which is another negative inotropic agent, which can be used in conjunction with an AV nodal blocking agent, or the septal reduction therapies that mechanically, anatomically reduce the left ventricular outflow tract obstruction. And we talk to patients about the pros and cons of each of those in detail and help patients make a selection that fits best with their particular circumstance. There are obviously benefits to each of them, and there are downsides. So the medication route is reversible. So a patient can try disopyramide, and if it doesn't work, then they have another option available to them. The success rate of disopyramide therapy is roughly 60% over an observational time period of 3 to 4 years in a randomized trial. So that's pretty good for a medical therapy for patients who have failed first-line therapy. Septal myectomy has been around for 50 years or more, depending on the center you're at, and the quoted success rates are in excess of 90%. The muscle doesn't regrow where the resection is done. Operative risks are low. The death rate is about 0.5% in the most experienced centers, with durable results. But that's cardiac operation. That involves a full sternotomy, cardiopulmonary bypass, and all the recovery period that's associated with that. Septal ablation is a bit newer. The success rate is not quite as high as it is with septal myectomy, and there's about a 10% need for reintervention in order to achieve the overall benefits, but it comes with not a big surgical scar, a quicker recovery period following the procedure, and those kind of things. So we talk through each of those things with our patients. And for the vast majority of patients, we can get them to a quality of life that they're happy with, where they're actively participating with their family and friends in life.
Terrific. So what goes into the decision-making for who gets medical management and who gets an implantable device?
Well, so the implantable device is a completely different discussion. So we have one discussion about how do we manage your symptoms should you have them. And then we have the second discussion about whether a patient gets an implantable defibrillator. And that's based on the risk profile assessment we do. And that has evolved to include a number of risk factors, predominantly how massive the hypertrophy is for an individual patient, whether there's a family history of sudden cardiac death, whether the patient has had syncope that sounds arrhythmic in nature, whether the patient has non-sustained ventricular tachycardia. Some of the newer risk models that we wrote into the guidelines this year include if a patient has a lower than normal ejection fraction in HCM, which is quite unusual, or if a patient has a left ventricular apical aneurysm, which is not that infrequent in patients who have apical distribution HCM. And now we're also looking at the amount of late gadolinium enhancement on CMR. And if that is more than about 15 to 20%, then that represents an increased risk for patients. And so our approach was to use those risk models to identify which patients have risk factors, which clearly means they have higher risks than patients who don't have those risk factors. And then to use the HCM risk prediction calculator to help frame the magnitude of the risk for that individual patient. So the class of recommendation is based on the presence or absence of those risk factors, and the counseling session involves portraying the magnitude of risk for that individual patient to help them make a decision for whether or not they want to pursue an ICD.
Wonderful. So it's clear that there's an unmet need for treatment. Can you tell us about the Explorer HCM trial with mavacamten?
Yeah, so mavacamten, and I think it's fair to point out that mavacamten is brought to us by the sponsors of this CME event, is the novel agent that targets the actin-myosin interaction at the cellular level. So it's a potent negative inotropic drug, and left ventricular outflow tract is mediated by states of hypercontractility and then also loading conditions. And the HCM community, both patients and providers, is very excited that we now have pharmaceutical companies targeting HCM for therapies. And mavacamten is the first of these to come out. The Explorer HCM trial took patients with symptomatic obstructive HCM and randomized them to usual care with beta blockers or to mavacamten, and it was a 30-week trial. And the results of the trial have gotten quite a bit of fanfare in the press, and that's because the vast majority of the parameters were pointed in the right direction towards improvement. There's one important one that we can circle back on that was one that causes concern, but in general, most patients saw improvement in gradient, in exercise time, et cetera. And so we were quite happy with that. In terms of framing the context of it, about 37% of the patients in the active treatment arm achieved the pre-specified study endpoint. That compares to about 19% or so in the standard therapy arm. So there was an incremental benefit of about 20% for the patients being actively treated with mavacamten. So putting that in context, I mentioned earlier that disopyramide had about a 60% success rate, at least for 3 years in the trial that's published out there. Mavacamten is showing 20% incremental benefit over 30 weeks. So we have to keep that in mind for this new agent as it comes in.
Great. So what were the overall takeaways then from this trial?
The overall takeaways are promising. And I mentioned there was one negative impact, and that is the potency of these myosin inhibitors meant that about 10% of the patients in the Explorer trial actually saw a decline in their left ventricular ejection fraction to less than 50%. And so knowing how closely systolic function is tied to adverse outcomes in HCM and other cardiac conditions, we really need to have longer-term assessments of the safety of mavacamten when we see that. Now, the nice thing in the Explorer trial was everyone who had that reduction in systolic function was reversible when they stopped the agent. So it's not a permanent issue, it's a reversible issue, but we do need to understand the long-term safety data. So for most of us that work in the hypertrophic cardiomyopathy field, we think the results are promising, but we need to see more data long-term. The other thing that is important to point out is that most of the patients in that trial were class 2 to begin with and were brought down to class 1, which is great. Patients who we're offering ablation and surgery to are generally class 3 or higher. And so right now there's another trial going on looking at those patients who have higher degrees of symptoms to see if those results translate into that symptomatic class as well.
Well, thanks, Steve. This has been a great discussion. Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely. That is, what exactly we hope our audience will take from this presentation to apply to practice. First, contemporary treatment strategies have transformed HCM from a common genetic heart disease with dire consequences to one that offers longevity and quality of life. Two, to apply updated guidelines to provide guidance regarding the management of HCM. Three, to refer patients with HCM for multidisciplinary care at comprehensive or primary HCM centers. And four, that new agents have the potential to improve care and the treatment of patients with HCM. As I mentioned, this is the second in a three-part CMEO Snack series on HCM. If you haven't already, please visit the Cardiology Education Hub on www.cmeoutfitters.com to participate in Part 1 and Part 3. Don't forget to complete the evaluation and collect your credit for today's activity. You'll be able to print your certificate from the platform. Thank you, Steve, for joining me today to share your insights into the new AHA-ACC guidelines for HCM. Thank you to our audience. I hope our discussion gave you new insights into the treatment of HCM.